Good evening. I want to welcome everybody to this week's Sage's Dermpath Happy Hour. I'm very pleased to, or we're very pleased to have Dr. Travis Vandergriff hosting again. Travis is currently on the faculty at University of Texas Southwestern Dermatology Department. It is in charge of dermatopathology there, and as well sees clinical dermatology, and currently has taken over the job as the program director for the residency there. So we're very pleased to have him discuss a series of cases this morning. And without any further, or this afternoon, without any further hesitation, I'll turn the floor over to Travis. Travis.
Thank you for the invitation and for the introduction. And I'll be going over, I think there's 12 slides today that I'll be reviewing. So our first case, I'm going to spin the slide around and just make it upright here. So our first case is a punch biopsy. And on scanning magnification, you can see that there's a little bit of papillary dermal edema and a superficial infiltrate of lymphocytes. So as we go to a little bit higher magnification, you can start to see that we have a superficial perivascular infiltrate of lymphocytes, and the infiltrate is forming small nodules around vessels. It's not really forming a dense band of lymphocytes, so it's more patchy than that. It's not really a band, so we're not thinking about a lichenoid infiltrate, more like a superficial perivascular infiltrate. However, as we go to higher magnification, we can see that the primary process here, or the primary reaction pattern, is vacuolar interface dermatitis. So vacuolar interface dermatitis is a process where you have basement membrane vacuolization, or holes being punched into the basement membrane. And it creates the appearance of tiny vacuoles or holes at the dermo-epidermal junction. An important part of vacuolar interface dermatitis is the finding of dyskeratotic keratinocytes. So anytime I'm thinking about, could this represent vacuolar interface dermatitis, I want to look for dyskeratotic keratinocytes as a way of corroborating that, because vacuoles along the basement membrane can be a little bit hard to tell if that's truly vacuolar degeneration, or maybe a little bit of spongiosis, or maybe papillary dermal edema. So sometimes that can be a tough decision to say, is that vacuolar degeneration or not? If you find dyskeratotic keratinocytes in the epidermis, especially if they're numerous, then that really confirms your observation that the pattern, the reaction pattern, would be vacuolar interface dermatitis. Remember, dyskeratotic keratinocytes have condensed eosinophilic cytoplasm and a hyperchromatic shrunken nucleus. So all of these pink cells here are dyskeratotic keratinocytes. So our differential diagnosis for vacuolar interface dermatitis, we want to go back out a little bit. When I'm thinking about vacuolar interface dermatitis, I always want to look at the cornified layer, and I look at the silhouette of the epidermis with a goal in mind of trying to decide, is this more of an acute eruption or more of a chronic problem? On the acute side, we have diagnoses like erythema multiforme, fixed drug eruption, and graft versus host disease. And then on the chronic side, you've got connective tissue diseases like lupus, subacute cutaneous lupus, or dermatomyositis. So signs of acuity would be a cornified layer that is basket weave. So I'm looking at the cornified layer and I see that it is a basket weave cornified layer. If it's a chronic process, you're going to get more compact orthokeratosis or parakeratosis. So this appearance of the cornified layer goes more with an acute process. I also look at the silhouette of the reedy ridges, and notice here that we still have our reedy ridges and interdigitating with dermal papilla. That's the appearance of an acute process of interface dermatitis. For example, in lupus or dermatomyositis, the reedy ridges become flattened or effaced over time. So those two things, the cornified layer and then the silhouette of the reedy helps you decide if you're dealing more with something acute or something more chronic. And then I mentioned the differential earlier, fixed drug eruption, graft versus host disease, and erythema multiforme. So to distinguish those, we want to look more closely at the specific cellular infiltrates. And I notice here that we have a lot of eosinophils. I don't have to look very hard to find eosinophils. Those eosinophils really elevate fixed drug eruption to the top of the differential. And a nice confirmation of that is the finding of melanophages, histiocytes that contain melanin pigment in the papillary dermis, and those represent pigment incontinence, which is another sign of this being consistent with fixed drug, which hyperpigments after an episode. So that is a interface dermatitis, vacuolar type, with a infiltrate containing eosinophils and melanophages in the papillary dermis, consistent with fixed drug eruption. The differential diagnosis with erythema multiforme, another clue that this is fixed drug rather than EM, is that the infiltrates are involving the mid-dermis as well. So in erythema multiforme, you have a superficial process, but the mid-dermis tends to not really be inflamed. So the fact that these infiltrates are also extending into the mid and deep dermis on scanning will suggest fixed drug eruption over erythema multiforme. Okay, I'm going to move on to the next one. Okay, so we have a biopsy here, which looks like maybe a shallow punch or a scoop shave. And as we go a little bit higher magnification, I can see it looks like there's a neoplasm. The epidermis looks to be a little bit acanthotic, and then there's some inflammation in the dermis. As I move into higher magnification, though, I can really start to see that, yes, there is a neoplasm, and it's intraepidermal. So there's a proliferation of cells in the epidermis. And these cells have a particular appearance. The cells are pale. They have abundant cytoplasm, and that makes the cells look large when we're comparing them to normal keratinocytes nearby. So the cells have abundant cytoplasm, which is pale. And also the cells are scattered throughout all levels of the epidermis. So you've got these atypical kind of large cells scattered at higher levels of the epidermis. So this is a good example of a pattern that's called Pagetoid scatter. So Pagetoid simply means that the process resembles Paget's disease. And Paget's disease historically was first described as a skin manifestation of underlying breast cancer, in which breast cancer cells come out on the skin affecting the nipple. And so to say that something is Pagetoid means that it resembles Paget's disease. And when we say Pagetoid, what we're saying is that the neoplastic cells have abundant pale cytoplasm, and that they are scattered throughout the epithelium at all levels in a kind of a random distribution. So all of these larger pale cells in the epidermis would be considered Pagetoid cells. So Pagetoid differential diagnosis is a classic differential for Dermpath, and we've got to think about some common diagnoses like melanoma in situ, Bowen's disease, and Paget's disease. We'll get into that in a second. And then you've got to think about some more rare diseases like Pagetoid reticulosis, which is a variant of mycosis fungoides. And then Merkel cell carcinoma and sebaceous carcinoma can also give you a Pagetoid architecture of cells. This is an example of extramammary Paget's disease. So the way that I work through that differential is I look first at the cornified layer. Squamous cell carcinoma in situ or Bowen's disease is usually going to give you confluent parakeratosis, and melanoma in situ and Paget's disease usually don't. So we have a basket weave cornified layer here rather than parakeratosis. I also look at the junction of the epidermis and the dermis. In melanoma, in situ, you get nests of melanocytes that are situated at the junction. In Paget's disease, you really have more single cells. Sometimes there can be nests or clusters, but they're situated right above the junction and they kind of compress or smash the basal cell layer, but they don't go down, hanging down into the dermis. Pagetoid cells, also in Paget's disease, will have a little bit of a grayish or blue color to the cytoplasm, and that's due to mucin. This is an example of extramammary Paget's disease. You'd have to get some clinical information to know that it's not from the nipple, but that it's from the anogenital area. Hence, we would call it extramammary Paget's disease. And this diagnosis requires a little bit of a clinical workup once it's made, because extramammary Paget's disease can be associated with an underlying adenocarcinoma of the pelvis, like the prostate or the colon or the bladder. And it requires some clinical workup with imaging to exclude that process. It may be, and in most cases, it usually is a skin cancer, which is an apocrine carcinoma in situ, but occasionally it can represent metastases into the epidermis from an underlying adenocarcinoma of the pelvis. Okay, I'm going to go on to the next one, which is an excision, a little bit larger excision here. And you've got a dome-shaped papule. And on scanning magnification, we're getting the impression of a benign silhouette. A benign silhouette will be one that is circumscribed, meaning I can pretty easily tell the boundaries of the neoplasm. Symmetric and small. So circumscribed means that I can tell the boundaries. Symmetry is judged by drawing a line and then deciding if the reflection across that line is roughly equal. And then size can be kind of hard to judge on scanned images. My rule of thumb is that a small lesion fits into a 4x field of view. This may be a little bit bigger than most of our small neoplasms, but overall a benign appearing lesion. And as I go to higher magnification, I can see, okay, we have in the superficial part of the dermis what look like nests of melanocytes. So I see nests of epithelioid cells with the gray cytoplasm here in the superficial part of the dermis. These are melanocytes. I can also go to the overlying epidermis and see there's a little bit of a proliferation of single melanocytes in the junction, a pattern that we would call lentiginous, meaning increased in single cells along the junction. But for the most part, this is a dermal-based neoplasm. Here at the edge, I've got a junctional nest. So this is confirming our impression of a melanocytic neoplasm, a compound process because we've got junctional and dermal nests. And then as we go to the kind of the middle of this neoplasm, it gets kind of hard to tell what are the neoplastic cells and what is part of the background stroma. Notice that you've got a lot of blood vessels mixed in. And the blood vessels are small, capillary-sized vessels, but they're increased in number beyond what would be normally expected for the dermis. In addition to that population of blood vessels, you also have in the stroma a proliferation of these epithelioid cells. And these are the cells that are resembling what we saw in the nests of melanocytes in the papillary dermis. So these are melanocytes, and then these are blood vessels. The melanocytes here have a round nucleus and abundant cytoplasm, which is a morphology we call spitzoid. A spitzoid melanocyte is one that has a abundant eosinophilic cytoplasm and a large nucleus. But we also have this background of blood vessel proliferation. So there's sort of these two processes going on simultaneously and merging together. This is a variant of a Spitz nevus that's called Angiomatoid. A Spitz nevus is a benign melanocytic proliferation with these nests of melanocytes in the papillary dermis, and then they disperse towards the base. What's unique about this variant of Spitz nevus is the concomitant proliferation of blood vessels in the background. And that proliferation of vessels can be so pronounced that it can even obscure your interpretation and make you think more about vascular neoplasms. But I think the best way to get this diagnosis is to recognize that superficially we have more classically appearing nests of melanocytes, and that can help you key into the fact that this is truly a melanocytic neoplasm rather than a vascular one. That is an angiomatoid variant of Spitz nevus. Okay, going on to our next case. Rotate this around a little bit. Okay, so we have a shave biopsy here with a polypoid silhouette. Polypoid means that you've got a narrow base, and then from that, the neoplasm extends upward in kind of like a mushroom silhouette. So it's pinched, narrow base or stalk, and then it expands more widely above that. That's called a polypoid silhouette. So that's what we have here. A polypoid silhouette, we usually think of those as being benign lesions. So the silhouette here is giving us an impression of a benign diagnosis. It looks to be pretty symmetric. It's hard to say exactly, you know, if it stops right here. Our circumscription looks to be pretty good, but regardless, on the silhouette, you get the impression that this is probably benign. However, we always have to examine on higher magnification before we commit to an interpretation. And as we go to a little bit higher magnification here, some alarming features start to display or become apparent. So what I'm seeing as I go to higher magnification is that we're dealing with a melanocytic neoplasm. I can tell that because we've got nests of melanocytes in the papillary dermis. Some of them are making melanin, which is this brown pigment, and that helps us also recognize it as melanocytic. What is alarming me is the architecture here, which shows a lack of maturation. So maturation is a process of architectural change in a nevus, where in the superficial part of the nevus, the melanocytes are larger, they have more abundant cytoplasm, and then as you go deeper into the reticular dermis, the melanocytes become smaller, they become more dispersed and less nested, and also fewer melanocytes per unit area. That's maturation. We're not seeing that process here. The melanocytes in the deep part of the dermis are remaining nested, they're crowded, they have abundant cytoplasm, and so that view there's just a little bit blurry, but there's nuclear atypia. So these cells look pleomorphic. And if I scan here, I think we'll find some areas where you've got mitotic figures. So a dermal mitotic figure in a melanocytic neoplasm is a very significant finding. And it's not one that you want to see in a nevus. So when you couple the findings here with lack of maturation, a stuffed or crowded dermis, and mitotic figures in the dermis, then we're diagnosing a melanoma. If we look at the overlying epidermis, there are a few clues as well. This would be a confluence of single melanocytes along the junction. That's not something you'd expect to see in a nevus either. So while the silhouette gives us a benign impression, our closer inspection reveals some features that are inconsistent with a nevus. So this is a melanoma, and because the silhouette looks benign, we would call this a nevoid melanoma. Simply meaning that it resembles a nevus on scanning, but it meets criteria for melanoma when you inspect more closely. And a nevoid melanoma is a tricky diagnosis because we are accustomed to making our first impressions on scanning. And so you may even be diagnosing this, without examining closely and miss the diagnosis of melanoma. That's sort of the classic pitfall with nevoid melanoma, is that the criteria are missed because you don't inspect closely enough. Here's a really good example of a dermal mitotic figure. So nevoid melanoma is a melanoma that on silhouette looks like a nevus. And just like any other melanoma, we would report this by measuring the Breslow depth, which is a measurement that you take with an ocular micrometer going from the granular cell layer to the base of the neoplasm, maybe right here. And you would measure that, report it in millimeters, and then check to see if there's ulceration or not. So this is an example of a nevoid melanoma. And these diagnoses really kind of confirm that our final diagnosis requires an inspection of the neoplasm, not only from scanning, but from closer magnification as well. We make our first impression at scanning level with silhouette, but then we confirm and assess more closely by going into higher power views. So that is a nevoid melanoma. Okay, next case is a punch biopsy. And it's a punch biopsy of a melanocytic neoplasm. So oftentimes when we see a punch biopsy, our first thought is that we must be dealing with something that is inflammatory rather than neoplastic. But sometimes people do biopsy neoplasms with the punch technique, so we have to keep our mind open to that possibility. As I look at this melanocytic neoplasm on silhouette, I'm struck by the wedge-shaped architecture. Okay. You've got a superficial proliferation of melanocytes here that descends into the dermis in a bulbous way. It has this wedge-shaped expansile silhouette, and then at the base, it's got this bulbous lobular architecture. As I come up here, I'm going to notice that these melanocytes here are round nuclei. They have abundant gray cytoplasm. This looks basically like a normal nevus here. There's maturation with descent, meaning these melanocytes disperse as you get smaller. There's a lot of pigment interspersed. So this is a typical finding here in this diagnosis, is the numerous pigmented melanocytes and then pigment in the stroma and in melanophages. Notice also that as we go deeper, the cytoplasm of the melanocytes turns into a little bit of a gray and foamy texture. And there's a lot of melanin pigment surrounding these. This is a deep penetrating nevus. And a deep penetrating nevus, I think of as being, in a way, pretty similar to a blue nevus, because the melanocytes in a deep penetrating nevus are present in the deep part of the reticular dermis. They are heavily pigmented, and they can have a spindle morphology. So instead of being just round, sometimes the melanocytes in a deep penetrating nevus will become spindle shaped. So we'll see these spindle shaped melanocytes, and then some that are more epithelioid or round. The cytoplasm of a deep penetrating nevus cell, a DPN cell, is a foamy gray cytoplasm that tends to have really tiny melanin particles in it, what's called finely divided or dusty melanin. And those cells are typical of a deep penetrating nevus. And you'll see them at the bottom part of a deep penetrating nevus, where it becomes this bulbous wedge-shaped growth. The melanocytes at the superficial part look a little bit more like your conventional melanocytes. They have nests forming here in the papillary dermis, not quite as much melanin. And then as you get down here, you've got a this specific cytological appearance with the gray cytoplasm and the finely divided melon. So that is a deep penetrating nevus, and on scanning magnification, it's going to give you this wedge-shaped, deeply penetrating or deeply extending silhouette. Okay, next case, this is the shave biopsy, again, with this polypoid silhouette. So you've got a narrow base that then expands above it to create a polypoid silhouette. We think about benign lesions, usually with polypoid silhouettes. As I go to higher magnification, I can see that we've got a couple of things going on here. I'm going to rotate this just a little bit. A couple of things going on here in this polypoid lesion. So it's ulcerated and crusted. There's some edema in the stroma, which is this pallor. There's also a proliferation of congested blood vessels. All of that suggests a pyogenic granuloma. So you've got the silhouette that looks like a pyogenic granuloma. As I go to higher magnification, I can see we also have a population of melanocytes here, small round melanocytes nested in the papillary dermis. They're dispersing as we go a little bit deeper. So you've got what is looks like a pyogenic granuloma, but is hiding or covering a nevus. So there's a melanocytic nevus here, an intradermal nevus, and it's become ulcerated maybe from trauma. And on top of that is some granulation tissue, making it look like a pyogenic granuloma. That would be considered two diagnoses that are sort of merging together. And I would think of it as a nevus, intradermal nevus, that has been traumatized and become ulcerated, and then hence some granulation tissue resembling a pyogenic granuloma. You also have, this is like the third diagnosis in this slide. So this is kind of an interesting combination and one that is not necessarily a common scenario. You also have this invaginated epithelium creating a little cystic space. And in that cystic space, the lining is showing a intracytoplasmic inclusion that is eosinophilic. It's an eosinophilic inclusion that compresses the nucleus of the cell off to the side. And as these cells mature and come to the apical surface of the epithelium, those inclusions are shed out into the cornified material. These are molluscum bodies, and this represents a concomitant and probably coincidental papule of molluscum contagiosum. So you've actually got three things going on here. You've got a nevus, you've got pyogenic granuloma, and molluscum. And maybe it was traumatized, maybe the molluscum ruptured and that led to the inflammation, but regardless, all three things kind of coinciding, we call that a collision lesion. In this case, kind of an interesting combination of nevus, molluscum, and pyogenic granuloma. Okay, next case. This is a punch biopsy. And on scanning magnification, it's not super obvious what's going on here. Is there a neoplasm? Is this something inflammatory? It certainly doesn't look to be heavily inflamed on scanning magnification. So this requires us to look maybe a little bit closer. And as I scan closer, I'm definitely not seeing a neoplasm. I mean, sorry, not seeing an inflammatory process. I'm noticing two kind of areas here that get my attention. One is this in the deeper part of the dermis. And then the other is in the more superficial part of the dermis. I'm seeing similar bundles. So as I inspect these a little bit closer, these are smooth muscle bundles. The nuclei of smooth muscle cells are spindle-shaped and blunt-ended. They're straight and blunt-ended like a cigar. So these are cigar-shaped nuclei. The cytoplasm is a pink eosinophilic color. And in the cytoplasm of smooth muscle cells, you find vacuoles, little perinuclear vacuoles. That is a typical feature for smooth muscle. So these are smooth muscle bundles, but notice that they're not situated around a hair follicle or connected to a follicle. These would be considered ectopic smooth muscle bundles. Going down here, you've got kind of a similar process here, some smooth muscle, increased smooth muscle in the lower part of the dermis. It's a subtle finding because smooth muscle bundles are normal constituents of the dermis, but what's abnormal here is that they're increased in number and they're not in the normal position, which would be connected to the side of a follicle. So this is a hamartoma of smooth muscle bundle, and we call that a smooth muscle hamartoma. If you put the additional features of hyperpigmentation and some increased terminal hairs, then you would call this a Becker's nevus. And this does have the conspicuous hairs here. So this could be a smooth muscle hamartoma or a Becker's nevus. And kind of a tough diagnosis because it's not like a out of place proliferation of cells. It's a normal structural element that is just increased in number and not in the normal anatomic configuration. So that is a smooth muscle hamartoma or Becker's nevus. Okay, got a shave biopsy here. This is a superficial shave that I'm going to flip upside down. And on scanning magnification, I don't really see an obvious neoplasm. So I have to go a little bit higher before I can really make a judgment as to what process we're going to be addressing. But as I move to higher magnification, I can see, okay, I do have a proliferation in the dermis, and it's roughly this area. And what's standing out to me are the spaces. So all of these little luminal spaces in the dermis represent the neoplasm in question. And it's usually blood vessels that create these luminal spaces. So we want to come on higher magnification and really confirm that and inspect. So I'm seeing a vascular proliferation. There is an increase in the density of vessels. And also the luminal space is it's dilated. It's bigger than what would be typically expected for just a normal dermal capillary. So I know we're dealing with a vascular neoplasm because we have increased numbers of vessels and their caliber or their size is not normal for this superficial part of the dermis. So we have a vascular neoplasm. It looks to be small. It looks to be circumscribed. I can very easily tell, the boundaries of this. I'm also noticing that the individual vascular lumens do not interconnect to make a complex network. They're just individual small vessels. So I'm thinking about benign diagnoses of vascular neoplasms, so a hemangioma. And there's some unique features here that help us to subclassify this hemangioma. We've got some extravasated red blood cells. We have a little bit of hemosiderin pigment, which kind of hard to tell, but I think that's probably some hemosiderin pigment there. And then also the endothelial cells. The shape of the endothelial cell here is bulbous and protruding into the lumen of the blood vessel. That is a shape or a morphology that's called a hobnail endothelial cell. Notice also that the vessels are bigger in the superficial part of the dermis, and as you go deeper, they become smaller and more compressed. These are all the architectural features for a hobnail hemangioma or targetoid hemosiderotic hemangioma. Hobnail hemangioma captures the histologic appearance of the nuclei of the endothelial cells, meaning they protrude into the lumen from a narrow base, and they have a bulbous expanded cytoplasm. So you've got this protuberant endothelial cells. Those are called hobnail endothelial cells. Targetoid hemosiderotic hemangioma, the synonym, is a name that captures the clinical appearance, which is a brown papule that has a targetoid appearance. So a lot of times when these are biopsied, they are clinically thought to represent melanocytic neoplasm. But the way that you diagnose this is to recognize that it's a benign vascular proliferation, that the vessels are larger and more dilated superficially, and that as you go deeper, they become smaller and more compressed. You'll find hemosiderin pigment in the stroma and hobnail endothelial cells. Those are the diagnostic criteria for a hobnail hemangioma or targetoid hemosiderotic hemangioma. If you're concerned or not 100% sure if there's hemosiderin deposition in the stroma, you can do an iron stain or a pearl stain, and that can help highlight that hemosiderin pigment. Okay. Going on to our next case, we have an excision. So this is a larger neoplasm, and it's excised down into the subcutis. And the neoplasm itself is situated in the dermis. Although it's large, it does have a benign silhouette. It's very sharply circumscribed, very easy for me to tell the boundaries of this neoplasm. And it's symmetric appearing. If I draw a line through this, one side looks pretty similar to the other with respect to the bulkiness or the architectural configuration. So I'm thinking about benign neoplasms. I am noticing on scanning that it is not directly connected to the epidermis. There's this gap or this zone of separation. So this is really truly a dermal-based neoplasm, not one that is originating from the overlying epidermis. The cells that are making up this neoplasm are basaloid or basophilic, meaning they take up hematoxylin and show a purplish color. I would also say on scanning that this has a architectural configuration that in one area is cystic, and in another area is more solid. So you've got this cystic configuration, a space that's widely dilated, filled with some secretions, and then this other space which is more solid and made up of cells. So it's a solid and cystic configuration. And that's an important architectural observation. As I go to higher magnification, I'm going to notice a couple of things. The cells that are making up this neoplasm are monotonous. They're very uniform in their appearance. They are round with eosinophilic cytoplasm. So each one of these cells looks very much like its neighbor. That is a monotonous appearing population of cells. I also see, not very many, but I do see some ducts, eccrine ducts. So these cells you would describe as poroid. Okay, poroid cells are a population of cells that have eosinophilic cytoplasm, round to oval nucleus, and very monomorphous and monotonous. And they are associated with eccrine duct tumors. So you've got rare eccrine ducts. So it's a poroid histology. And then as I look around here in the stroma of this tumor, I notice that there's a lot of hyalinized collagen. Hyalinized collagen is eosinophilic and very smooth. So these little bands of collagen have become hyalinized in the stroma. That type of stroma with hyalinized bands of collagen is a hidradenoma stroma, the stroma that's associated with hidradenomas. So hidradenomas are sweat gland tumors derived from eccrine sweat glands. And there's some significant overlap with the family of eccrine tumors called poroma. So poromas are eccrine tumors usually connecting to the overlying epidermis. Hidradenoma is a little bit different because it's more of a dermal-based tumor and it has this nice hyalinized stroma. And occasionally they will overlap, like in this case, you've got the poroid cytology and a more an architecture that's more fitting with hidradenoma, especially that solid and cystic architecture. So this is a lesion that you would call a poroid hidradenoma. It's kind of like you can't quite make up your mind. Is it a hidradenoma or is it a poroma? If I look closely at the cells, I'm going to favor a poroma based on their monotonous appearance. If I zoom out and look at the silhouette, I'm going to favor a hidradenoma. I would say maybe a solid and cystic variant of hidradenoma. So when I combine those two and can't quite decide, I call it a poroid hidradenoma. I think of these basically like variants of hidradenoma. That's sort of the primary, like if you were to look this up in a textbook, it would go under the category of hidradenoma. And for hidradenoma, one of the things I really like to find is this hyalinized stroma. So that collagen is super pink and smooth. And that's a nice example of what the stroma is supposed to look like for hidradenoma. Okay, next case. A punched biopsy into an ulcerated plaque or an ulcerated papule. The epidermis on this side is showing us a defect. That's the ulceration. And then the primary process is this dense and diffuse dermal infiltrate. So you've got a really dense dermal infiltrate here. It extends even deeper, but very dense up top. I'm also noticing that the overlying epidermis is acanthotic. We've got this area where it almost gives the question or impression of, could this be a neoplasm of the epidermis? It's an acanthotic epidermis. That is called pseudoepitheliomatous hyperplasia. And it's a reactive change in the epidermis to an inflammatory process. As I go to higher magnification here, I can see, okay, what is the inflammatory process in question? And I would say that it looks granulomatous. Granulomatous basically means that the histiocytes are the predominant inflammatory cell type. And I make that call by saying that the cells here are pale. If it's a lymphocytic inflammation, the cells are going to be dark blue, and it will make, on scanning, it's going to make the infiltrate look more dark. I'm seeing a lot of pallor here in these inflammatory cells. So that makes me think granulomatous. Okay, as I go to higher magnification, I'm going to confirm my suspicion. Say, okay, yep, we got a lot of histiocytes here. Now there are definitely some plasma cells mixed in. So it's histiocytes and also some plasma cells. And then as I go up here a little bit closer, I can see what these histiocytes are reacting to are organisms. These organisms are really small. In fact, they're so small that the details can be a little bit hard to see, especially on a scanned slide. If you had a microscope with a 40x objective, you'd probably see just a little bit more clarity or detail on these organisms. But look how small they are. You can tell that they're small if you compare them to an erythrocyte or a lymphocyte. An erythrocyte or a lymphocyte will measure approximately 7 microns in diameter. So these organisms are like a fraction of that. So maybe like 1 or 2 microns. They're super small. And it looks like they're in histiocytes. It looks like they're in the cytoplasm of these histiocytes. So my main differential here would be Leishmaniasis and histoplasmosis. And there's a couple of clues to help you distinguish Leash from histo. Leishmaniasis, at least the New World variants of Leash, like to arrange the amastigotes, or the organisms, at the periphery of a parasitized histiocyte. That's called the marquee sign or the Ferris wheel sign. It's basically like a configuration at the periphery, like the light bulbs at the movie theater that announce the movies. That's the marquee. And that's the configuration at the peripheral rim of the histiocytes. That's one clue to this being leash rather than histo. And then the other clue is hard to see, and I'm gonna venture to say that we don't have the necessary resolution on the scans here to see it. But that is the kinetoplast. A kinetoplast is a microorganelle within a Leishmaniasis amastigote. And it gives the amastigote a little bit of a hyperchromatic dot at the periphery of the organism. So basically, what that means is you're looking at something that's super small, and then you're trying to identify something that's even smaller inside of that already small organism. So you do need a good high-powered objective to detect that. But suffice to say that in Leishmaniasis, there's like, the organism is round, but at one pole you get this hyperchromatic dot, and that's called a kinetoplast. And you can see them with a 40x objective, and you would not expect to see that in histo. So because of the configuration at the periphery of the histiocytes, and then also looking for kinetoplasts, you would diagnose this as Leishmaniasis. Okay, moving on to our next diagnosis. Okay, so we have a shave biopsy. I mentioned earlier that shave biopsies are often performed for neoplasms and punch biopsies for inflammatory diagnoses, but that doesn't always hold true, so we have to keep an open mind. And what I see on scanning is most of this skin looks normal, but there's an obvious cluster of action here that I don't know yet if it's neoplastic or inflammatory. I'm still thinking of both as possibilities. As I go in on higher magnification, though, I can see, okay, this is a little ball of inflammatory cells. And I like how this ball of inflammatory cells is really contained within the dermal papilla. It's a small little cluster of inflammatory cells. It's made up of lymphocytes and histiocytes. Histiocytes being these larger, more pale cells, lymphocytes being the smaller, darker cells. So this is a lymphohistiocytic infiltrate. It is causing an overlying interface dermatitis. So this is a lichenoid reaction pattern. You've got interface dermatitis, you've got a band or a nodule of inflammatory cells abutting the junction and obscuring it. So it's an interface lichenoid reaction pattern, but it's not really a band. It's more of like a small, tiny nodule. And it's lymphohistiocytic. So your description here would be a lichenoid granulomatous infiltrate that is limited to the dermal papilla, which is expanded. And then also notice you've got this elongated reedy that comes down around the side and kind of hugs it or contains it. This is lichen nitidus, and lichen nitidus is a inflammatory pattern that gives you lichenoid granulomatous inflammation, abutting the junction, forming a small nodule rather than the typical band that we associate with lichen planus. And the classic description of lichen nitidus will include reedy ridges that come down around the edges and kind of grab or contain or circumscribe that inflammatory nodule. And it's described as ball and claw, kind of like those games at the arcade where you drop the claw and try to grab a toy, and that is the appearance of that infiltrate. So lichen nitidus, lichenoid granulomatous inflammation, a small nodule with elongated reedy ridges containing it at the side. Okay, last one is a punch biopsy. It looks like we're on acral skin because the cornified layer is very thick and we don't have any hair follicles. So we're a punch biopsy on acral skin. What I'm noticing on scanning is two things. One is massive papillary dermal edema. Papillary dermal edema is going to make the papillary dermis look pale, and it's also going to expand the height of the papillary dermis. So papillary dermis is expanded by edema, making it look pale. I'm also seeing a perivascular and periadnexal infiltrate of lymphocytes. Let me flip that around again. So a nodular infiltrate of lymphocytes, which is perivascular in the superficial part of the dermis, and then perieccrine. This is super important. You get these nodules of perieccrine inflammation. There's even some edema down here by those nodules. And then I come up here and I look at the infiltrate, and I see it's mostly lymphocytes. So a lymphocytic infiltrate on acral skin with massive papillary dermal edema and perieccrine inflammation. This is Pernio. Okay, so Pernio we can also call chilblains. Those are synonyms. And the differential diagnosis here would include polymorphous light eruption. PMLE, or polymorphous light eruption, is going to give you a perivascular lymphocytic infiltrate like you see here. It's going to give you massive papillary dermal edema, but it's not going to be situated on acral skin. And it usually doesn't give you this prominent perieccrine inflammation as well. So we differentiate based on the perieccrine inflammation and then also the acral location. Your differential will also include tumid lupus. So tumid lupus is a variant of chronic lupus that has a perivascular and perieccrine infiltrative lymphocytes. It is not going to give you this massive papillary dermal edema, but rather would have interstitial mucin. So what is increased in tumid lupus is not edema, but rather mucin in the interstitium. And if I go look at the interstitium here, I don't see mucin here. This is all empty. So that's your differential for this silhouette of this nodular lymphocytic infiltrate. You want to get a sense for the location and then also make a decision about what's going on in the dermis. Is it papillary dermal edema or is it mucin? This would be Pernio. You could also call it chilblains. And that is our last example. If there's any questions or comments, I'd be happy to address those. Just want to thank you for participating.
Thanks so much, Travis. Your insights and descriptions are always so great, and you know we all learn from them, so really appreciate it. If anybody has any questions, either if you're watching live or via video, you can always send them to education@sagesdx.com, or you can email me directly, tdavis@sages.com, and I can pass them on to you, Travis. But once again, really appreciate it.
Sounds great. Thank you.
Thank you. Have a good evening.
Bye.